So good day, all. Welcome to Global Men's Health Week. Welcome to our celebration of that and our effort to honor that with this brief webinar. I'm Professor Derek Griffith, Chair of Global Action on Men's Health and Director of the Center for Men's Health Equity at Georgetown. Also there, I'm Professor of Health Management Policy and Co-Director of the Racial Justice Institute. On behalf of Global Action on Men's Health, I'm delighted to chair this particular webinar and to be your moderator for today. So what we're going to do today is, well, first of all, again, thank you and welcome for joining us. If you don't mind, please, just as a way of hearing and finding out who's here, put your name and organization in the chat. Please feel free to use the Q&A feature to ask questions and so forth. And definitely we want you to participate and for this to be an active participation. And we'll try to have an active Q&A at the end of the remarks. So today, just quickly, I'll start with just the welcome and introduction as we're doing right now. Then we'll have our presentation, our feature presentation by our report authors, Dr. Natalie Leon and Professor Chris Colvin. Brief responses, as you can see, from Professors Richard Sullivan and Hendrik van Poppel, and then have open discussion and then close it out. Again, we're going to try to do this within an hour, so just to make sure we're respecting everybody's time. So why are we doing this? We know that globally, men have a very high incidence of cancer mortality and certainly higher rates than women. And 1 in 8 men dies from cancer by the age of 74 compared to 1 in 11 women. And the problem hasn't, despite this pernicious problem, despite the persistence of this problem, it hasn't generated a significant policy response at really any level, whether it's local, state, national, regional, meaning region of WHO region or globally. And Global Action on Men's Health has been trying to raise awareness of this and then bring some of this attention to this specific issue, and particularly as a way to begin to advocate more formally for what are some tangible things that we want to see actually happen in the years coming forward to start to advocate for these issues to be addressed. With generous funding from the Advanced Accelerator applications, so thank you to them as well. We've commissioned, Global Action on Men's Health has commissioned Drs. Leon and Dr. Colvin to review how men are treated in cancer policy, and that will, of course, be the main feature of our discussion today. The report is published by Global Action on Men's Health on our website today, and they'll be shortly presenting their findings, and the link for the report will be in the chat. And then again, the report will be followed by brief comments from Professor Sullivan and Van Poppel. Thank you, Peter. Then again, open discussion, Q&A, and so forth. And we definitely want to, again, think tangibly and have your advice, support, engagement. What kinds of things should we be doing in this space to raise awareness, attention, and to begin to formally advocate or continue to advocate for this type of work? I don't want to make it sound like we haven't been doing this as Global Action, but this is, and with other partners that we have as part of our network and organization. But who are the others that we should be engaging? Who are the others that we should be working with, talking to do this work and to create the change that we seek to have? So let me just briefly introduce our key speakers for today. Dr. Natalie Leon is a health systems and public health researcher with an honorary affiliation to Brown University in Providence, Rhode Island. She also works with the South African Medical Research Council, but she's actually coming to us today from not too far from me, and I'm in the DC area. She's in Charlottesville, Virginia. So ironically, her co-author here, Dr. Colvin, is a professor in the Department of Public Health Sciences at the University of Virginia with honorary affiliation at University of Cape Town and Brown University. And I believe, as she was remarking earlier as we were getting prepared, they've kind of switched places. So I believe Dr. Colvin is in South Africa while Natalie is here in the States. So with that, I believe I will turn it over to them. So thank you so much.
Thank you. Let me just get my slides up here. Okay, I'm going to take you through kind of a framing of the project. And then Natalie's going to walk us through the findings, and then I'll come back with a brief discussion on the policy advocacy kind of section at the end of the report. So just a brief outline, we're going to talk about what the problem is we're trying to address, what the aim of the report was, and the methods, which I'll again take you through very briefly, and then our findings and next steps. So what is the problem? Derek Griffith, kind of in his introduction, took us through some of the key forms of gender inequity in cancer burden of disease and unmet health needs. Higher burden, these patterns have been kind of persistent over time. There's important variations in terms of how they intersect with social determinants, geographic variation, with recent kind of large increases in LMICs. And really the kind of originating kind of motivation for the report was a sense of this quite clear gap in policies addressing male kind of inequities in cancer burden. And so the idea is to increase policy attention to these unmet health needs. And the kind of perspective here is that a gender equity approach has long been, kind of the lens through which a lot of work around women's health has been done and done successfully. And what we're trying to do is extend that approach to now thinking about men and men's health needs in the same way. And to do this for cancer, we need to better understand, to begin that process, that we need to better understand the gaps in global cancer policy in order to inform the kind of advocacy for more equitable policy and practice. Let's see. So the aim in this report is twofold. We reviewed global and regional cancer policy-related documents. And first looked at the ways in which men were currently considered in those documents. And by policy, we had a fairly broad definition of what policy was. This could include guidelines or best practices or other kind of statements of principle or frameworks for action. And these are either at global or kind of large regional kind of, WHO size regional organizations. And then in the final section of the report, there's a part where we look at policy advocacy strategies for moving this work forward. This was a rapid review. It's not a literature review of the scientific literature, but we did do a kind of a rapid scoping of the organizations and documents and policies that are out there. Made a selection from among the ones that we found in consultation with GAMH and its board. And then you'll see how we have kind of organized and synthesized the findings when Natalie takes us through the findings. And so with that, I'll hand over, I think, to her.
Okay, thank you, Chris. So I'm going to start off by reflecting on how gender is considered through sex disaggregated data, looking then specifically at gender and gender equity considerations that were mentioned, and also more specifically how are men referred to in the reports generally with reference to prostate cancer and HPV vaccination, and make a few summary remarks at the end. Next slide, please. So just briefly to start off with, we reviewed 28 reports. They were reports on general cancer policy, international and multinational organizations, as well as general cancer policy from international research organizations, NGOs, advocacy organizations, and I've given examples in the next column. Then we focused in on HPV-related policy-related documents, lung cancer-related ones, as well as risk factors. So we looked at NCD, international policy, risk factors, and some other, philanthropic type NGOs. Next slide, please. We know that sex disaggregator is important for understanding gender distribution and inequities. However, most documents provided no or limited sex disaggregated data. Where this was available, it was largely with reference to sex-specific cancers, such as cervical cancer, breast cancer, and prostate cancer, rather than the top 5 or 10 general cancers for mortality. Some reports did provide more disaggregated data, and there are examples of those reports there. Both European and European cancer organizations and an American disparity report, and I'll refer more to those later. Next slide, please. So this is just one example of how sex disaggregator data is presented, such as there would be 1 or 2 figures in the report at most often, giving the top burden or the top mortality cancers. Next slide, please. A few reports did acknowledge that there is a gap in gender sex disaggregated data, and there's a need for more. In general, it seemed as if the reports that had a specific focus on disparities had more sex disaggregated data, such as the ECHO HPV elimination report and the US disparities report, and that global reports had less data. Next slide, please. With respect to gender and gender equity considerations, there was little and cursory mention of gender disparities, and or gender inequities in these reports. Reference to gender was mainly seen as a social determinant of health disparities alongside other social determinants, as you would see in this quote, which you can read at your leisure when you review the slides. There were a few references made to gender perspectives in interventions. For example, taking a gender perspective, gender equality, gender appropriate, gender mainstreaming, and gender neutral references, but mostly with little or no further explanation. Next slide, please. There was little to no mention of men's health disparities in reference to general non-specific cancers. Where there was reference to men's health, this was mostly cursory, as is shown in this report, where, for instance, the first sentence, mortality rates for colorectal cancer are substantially higher amongst men than women. Those are very few of those references, and the explanation given there is actually quite comprehensive compared to most reports. Next point. There was cursory mention of men's risk factors for cancer, for example, high rates of smoking, gendered alcohol use, gendered service utilization patterns, and differences in body mass index. Next slide, please. Most gender-related references were to women's sex-specific cancers, especially breast and cervical cancer, as well as one report referring to women as a vulnerable population group in prisons. Next point. And there was, however, less mention of men's-specific cancer needs, and where this was done, it was mostly in relation to prostate cancer. Next slide, please. With respect to prostate cancer, a few reports made reference to global preference. Next point. As well as to race and class disparities, but specifically in the US disparities report. And in that report, there was specific reference to the fact that in 2012, there was a recommendation against prostate cancer in the US. And subsequently, there were substantial increases in prostate rates amongst Black men in the US compared to white men. Next slide, please. Recommendations for prostate cancer still differ across reports globally, with some being for, against, and some being in between. But there is increased attention to the need for expanded cancer screening, including for prostate cancer, as is shown in this EU report on cancer screening. There is recognition that equal and equitable access along the full continuum of care can reduce cancer disparities, and there's specific reference to the need for Black men, for instance, in the US to have much earlier age access to cancer screening. Next slide, please. With respect to HPV vaccination, there is a lot of focus on women, but not discussion of gender disparities. In summary, there's indications that more countries provide vaccination for women compared to men, with specific targets for women, but not so much for men. There is, though, more recently, more increased recommendations for vaccination for both men and women, but guidelines still differ, with some saying possibly for men and others saying men should be a secondary target group. Since 2019, though, there is more indication of recommendations for equal access, referred to as universal access or gender-neutral approaches, including harmonizing the age groups for vaccination. Next slide, please. There is, however, in general, little to no HPV-related male equity considerations or gender analysis. However, the exception is the ECHO report, the European Cancers Organization's report on HPV elimination, where they focus in on men and women burden of sex-specific and non-sex-specific HPV-related cancers. They talk about male inequity directly, with referring, for example, to the high risk of oral HPV among men. They address high-risk male groups, such as men who have sex with men, and they make a gender-neutral recommendation to access equitably male and female HPV-related needs. Next slide, please. This report provides very explicit rationale for a gender-neutral vaccination approach, stating that female vaccination alone does not provide sufficient protection for HPV for heterosexual men, that men have poorer immune response to HPV compared to women, which leaves them more vulnerable to reinfection. That human rights, ethics, and equitable principles should apply, and noting the unfairness of excluding men from a potentially life-saving intervention, as is shown in this quote that is quite explicit about the issue of possibly the discrimination, sex discrimination being possibly unlawful in this case, and noting that long-term cost-effectiveness of universal HPV vaccination could be established, though that should not be the only factor, and ethical and patient satisfaction considerations should be included. Next slide, please. They make 4 areas of recommendations: a gender-neutral vaccination with a 90% vaccination rate for both genders, vaccination programs for high-risk groups, better treatment and improved survivorship for HPV-related cancers, and education raising awareness about HPV and the risk, as well as an overall recommendation about collaborative and governance mechanisms to implement these action areas in Europe by 2030. Next slide, please. So in summary then, there's little substantive attention being paid to gender dynamics of global cancer epidemiology and cancer care. Next point, please. Gendered aspects were focused mostly on women. Where sex disaggregated data, gendered aspects were considered, these were mostly through sex disaggregated data and a couple of references to gender interventions. And men's needs and male equity policy initiatives are largely absent from these policies. And finally, reports on prostate cancer and HPV elimination engaged more directly with men's health, though global guidelines still differ considerably. And here we'll hand over to Chris. Thank you.
Okay. So what I'm going to do is take you through the kind of thoughts we had in that last section about the policy advocacy kind of approach going forward. We've used this Kingdon 3 streams model of policy windows of opportunity and agenda setting to organize the ideas. For those of you who don't know the framework, it's just a useful heuristic for identifying work that can be done to frame the problem, work that can be done to develop and promote policy options, and work that can be done to improve the kind of political environment and the likelihood for success. So in each of these areas, we've identified some ideas. In the problem stream, we've looked at 3 different areas. The first is to build a robust, nuanced, and diverse research evidence base about the problem. And a few points about that. There are some really critical variations in subgroups that need to be paid attention to. But at the same time, it's important to learn both across subgroups, of men, but also to work across different illness and areas of health. There are a lot of risk factors for cancer. There are also risk factors for other communicable and non-communicable diseases. And so that evidence base need not, probably important that it's not limited only to kind of cancer and men. The second point here is to work to make this evidence base accessible. This evidence doesn't present itself and needs to be kind of packaged and delivered strategically. And finally, leveraging interest in existing areas of concern. We've noted in the report a kind of ongoing interest in HPV vaccination and the recognition of vaccinating boys for HPV, but also debates around prostate cancer screening, and more recently, recognition of issues of men and COVID-19. So these are some kind of areas where interest could be leveraged for more general kind of concerns. In terms of the policy stream, which is about developing the policy options to choose from and developing the evidence in relation to those policy options, we also need a robust, nuanced, and diverse evidence base on interventions. And obviously the evidence base for interventions is quite different than the evidence base for the problem, and in many ways harder to kind of develop. Again, we note in the report that it's really important to learn from experience across disease domains. There's a great deal of work. There's more work in men and sexual and reproductive health, including HIV. And a lot of those lessons are, I think, importantly transferable. We need to consolidate and build from emerging best practices for men in cancer. There's some important innovations that we've innovative kind of reports and policy frameworks and recommendations that we have identified, few as they may be, but building on those kind of early gains in policy is important. We need to leverage the growing number of national and global men's health policies and advocates here. And again, there's a kind of a theme about the need to integrate so that men's health policies aren't populated by lots of small recommendations from small subgroups of, special interest groups. So another plea to kind of try to work as much as we can across our various population and disease silos that we tend to get trapped in order to kind of work together. And finally, leveraging interest in current promising areas of intervention. So prostate cancer screening and the kind of recent kind of conversation around that might be one example, and there are others. And then finally, in the politics stream, the politics stream is the stream that generally we have the least control over because it's often about the way the kind of external environment is configured and when windows of opportunity open up or don't. But there are things that we can do. The first is leveraging parallel policy developments, whether they're for women or for men or other health issues. There's a nice example we mentioned in the report of the Men's Health Forum in the UK taking advantage of the UK's announcement of a national women's health strategy to advocate for a national men's health strategy. There's been also important kind of attention paid at the WHO and the FCTC around tobacco control and gender, which maybe represents another opening. And then the last point is about the importance of long-term coalitions and networks. Again, moving outside of a kind of disease and population, kind of silo, taking advantage of political opportunities that present themselves requires more than kind of ad hoc efforts to link, campaigns or sectors or interest groups. So those kind of longer term coalitions are really important to work on slowly and steadily, so that when there are real opportunities, they can be taken advantage of. And I think that's it. Yeah. So just a thanks to Peter and to the GAMH executive for commissioning and supporting this. And I think we're going to move on to comments. First, you'll have to correct me if I'm wrong, Peter.
No, you're right.
Okay.
No, thank you both. Yes, thank you both Drs. Leon and Colvin. Now we're going to turn to our two respondents. Again, Professor Richard Sullivan, who's Professor of Cancer Policy and Health at King's College London, and Professor Hendrik van Poppel, immediate past chair of Department of Urology at Catholic University Leuven in Belgium. That was my best effort to try to circumvent trying to actually trying to avoid butchering your native language there. So I will turn the floor over to you, gentlemen. So I don't know which of you prefers to start, or if you have a preference.
I don't mind, Chuck. Do you want me to kick off, Hendrik?
Go for it. Yes.
I do that? Why not? Just a few minutes. Well, hello, ladies and gentlemen. Marvelous to be with you. I'm speaking from Guy's Hospital. Let me begin by huge congratulations both to Professor Colvin and Dr. Leon. It makes a refreshing change to read a report that's not just evidence-based, but actually connected to policy. Most reports provide a lot of evidence, but they don't make any attempt whatsoever to connect it into a systematic application to policy. So really huge congratulations. And I think this is long overdue. Sadly, I've been working in this area for too long. Like Hendrik, I'm actually a urologist by background, but I've been working on global health for many, many years. And I remember back in, I think it was March 2018, when the Bill and Melinda Gates Foundation, in their Global Health 50/50 report, appealed to the global health organizations to redress the, as they put it, inconvenient truths of men's health gaps, the absence of attention to gender dynamics in the global health agenda setting. And as they made the point, men engaged with health services, they're less included in policy decisions, and those men that do enter treatment, be it for cancer or other diseases, are more likely to drop out for a variety of reasons. And the reality is, as it's been very well articulated in this report, is the global health community writ large has, for a variety of excellent reasons, been focused very heavily on women and children over the last decade through all sorts of vertical and horizontal programming. And men in that sense have been left behind, and particularly in cancer. When you look at the WHO pillars at the moment, they focus on elimination of cancer of the cervix, breast cancer, and childhood cancers. I can't remember a meeting I've been to at the WHO, where I'm an NCD advisor, where men's cancers were brought up in any shape or form, or indeed a male gender perspective on other generic cancers like colorectal. So it's absent from WHO, it's absent from other groups like the IEA, Raise for Hope, radiotherapy program, and it's absent from that, what I would call macro policy discussion. Prior to this, I also had a good look through a lot of the reports on national cancer control programming. And again, what you've seen over the last decade for NCCPs is a welcome increase in the development of national cancer control programs. But within that, when we talk about gender and gender focused actions, what they're meaning is focused entirely on women. So it's already been articulated the growing problem of prostate cancer in sub-Saharan Africa, and generally, as we know, significant problems with men accessing and utilizing cancer services across many, many different environmental systems in low middle income countries simply is not brought out in those national cancer control programs. So I think you really hit the nail on the head and the need to address this in a systematic way. I think from a policy perspective, it's a difficult area. Maybe we can talk a little bit more about in the Q&A section to traction this, because I think when it comes to policies, we are talking about as Westphalian. Countries are still responsible for their own national cancer control plans, and getting into those is quite tricky. Certainly when you think about writ large who influences them, let's say somewhere like India, a lot of the power sits within National Cancer Grid of India, for example, but I certainly know they have no male gender perspective, for example, but those are the sort of policy influence areas one can go into. At the more regional level, organizations like Aortic, for example, which is this big pan-African organization that brings together care and research, interesting enough, being run from Dakar this year, and being led actually by a urologist, Seren Guye. So you talked about, I think, opportunities right at the end of being able to move the agenda forward. I think there are potentially lots of policy opportunities, and probably this requires amplification through major organizations that are engaged in global cancer. And I'll leave Hendrik to talk more about high income settings, but certainly in low middle income settings, I'm thinking of, for example, CCAN, for instance, the City Cancer Challenge. So these are big organizations which are embedded and influencing national and super regional policy in cancer. And I think first and foremost, it's recognizing that we do have a significant problem here, and that a male gender approach is an equal and complementary work stream to women's cancers. In October this year, the Lancet Commission on Women's Cancers will be published in Geneva. And I'm just wondering, perhaps, and just thinking off the top of my head, whether there's a real opportunity here to also then put forward the male gender perspective, and to basically re-articulate all the findings you've had here, but situate them at a political and policy level that will take the agenda forward by other complementary partners. And I will stop there and hand over to Hendrik. But again, once again, huge congratulations to both of the authors for some exceptional work. I really mean this. I really enjoyed reading the report. Thank you.
Thank you. Hendrik?
Excellent, Richard. Myself, I'm indeed Hein van Poppel. I'm a urologist from the Catholic University Leuven in Belgium, as was said. I want to thank the Global Action on Men's Health and Peter Baker for involving me in this webinar. That is really excellent. As chairman of the Policy Office of the European Association of Urology, I have been fighting now for more than 5 years for inclusion of prostate cancer screening in the new recommendations of the European Council, and this has just come true at the end of last year. I came across of a lack of prioritizing men's cancer when I chaired the Inequalities Network of the European Cancer Organization, ECHO. Notice to everybody that I'm happy that our female counterparts receive much attention, and the healthier women are, the better. And we should not go into competition and lower the care for women and increase the care for men. But the figures are there and are indeed disturbing when it comes to men compared to women. And as a urologist, allow me to just share some comments on male cancers in the genitourinary field. I'm fully aware that a lot of what we perceive as a gender-related discrimination has to do with men themselves. We are different. They do not care about health if they're happy, without symptoms, and function well. They do not talk about it. It was shown in a survey by the European Cancer Patient Coalition for Prostate Cancer that in the European Union, 45% of men do not know about the prostate and do not know about prostate cancer and eventual testing. They are much less going for population-based screening, for instance, the experience we have with colorectal cancer as compared to women. So I fully subscribe the analysis that Natalie, Leon, and Chris Colvin have presented and the action points as worked out. Men are indeed about absent from cancer policy in the EU and worldwide. But there is hope, I think. There's first gender-neutral HPV vaccination. Testis cancer here and there gets more attention, but still needs more awareness campaigns on self-examination, watch your balls, for instance. And then I once argued that the Europe's Beat Cancer Plan could not be taken seriously if they do not include or prioritize prostate cancer. That is the #1 incident male cancer in the European Union. Now, since the recommendations against PSA testing, there has been a clear increase in too late diagnosis in metastatic incurable prostate cancer in too late stages. In the UK, today more men die from prostate than women from breast cancer. And still screening programs remain controversial. In Scandinavia, in the Baltic states, the north of Europe, prostate cancer is the #1 male killing cancer. In most countries in Europe, it's #2. In the south, it's #3 killing male cancer. So we are happy that the European Commission, after, as I said, more than 5 years of lobbying in the European Parliament, in and around Brussels, trying to convince them, has finally accepted to advise a stepwise approach to the implementation of screening for prostate, lung, and gastric cancer in the European Union. And we really hope that this will pave the way for further improvement of men's health. And I leave it there, and thank you.
Thank you for those remarks. Now I think we're going to open it up for Q&A and other reflections. I see we have a question from Dr. Mike Rovito in Florida. So I'm not sure if either Dr. Leon or Dr. Colvin, if you have a preference for who answers this, but the question is, can you speak to how the U.S. Preventive Services Task Force factored into your analysis pertaining to U.S. men's cancers, their methods and their influence?
I can answer that. I did not review reports specifically from that organization. The information reported was within a U.S. Cancer Disparities Report, and there they refer to statistics in relation to pre and post the recommendations against cancer screening and the dramatic increase in prostate cancer rates, especially amongst Black men. So I'm not able to answer that indeed.
And I'll maybe also add that, you know, I'm not exactly sure what, Michael, your question is here, but, you know, our focus was on the ways in which men and gender appear and organize the kind of discourse of the policies. And we don't really get into the kind of content, you know, or the kind of debates over prostate cancer screening or whatever, you know, other particular kind of content there might be.
Okay, thank you both. So there's another question by Natalie Fernandez. What might you suggest for screening for prostate cancer since other PSA testing strategies were not accepted? I don't know if, yeah, this is for any of the four of you. So.
Can you repeat the question, please, Derek?
Sure. I think her question is, what might you suggest for promoting, I'm going to add words, so Natalie, please correct me if I'm incorrectly sort of summarizing, but what might you suggest for promoting prostate cancer screening since other strategies to promote PSA testing were not accepted?
Yeah, there is a big difference. The problem with the PSA screening obviously was the overdiagnosis and overtreatment that we have overcome. And instead of continuing speaking amongst researchers and clinicians, we have started talking this language to the policymakers and the politicians at the European Parliament and the European Commission. What the Commission did at the start of the Europe's Beat Cancer Plan is give the task to the SAPIA, which is scientific advice for European academicians on certain issues, to look at the value of screening. And the 3 cancers were included, also ovarian was included. Finally, they ended up with saying that for prostate cancer, the way we can do risk stratification, including PSA density, prostate volume, age, ethnic race, family history, prostate volume, as I said, and finally MRI. All these have been able to really minimize overdiagnosis and overtreatment. That the Commission realizes that instead of making money, to spend too much money for the opportunistic screening that we do today, that does not impact on mortality, that does not avoid overdiagnosis. Really, in the end, there will be an economic benefit of having an organized screening program. And this is what they have translated finally in a report, SAPIA to the Commission to the Council. That was not the end of the story, because we were going for implementing prostate cancer screening globally, risk stratified. The Council then has to discuss this with the Member States, and the Member States have weakened down actually the message that was given by SAPIA and by the Commission, and that we inspired them to tell in the end. And finally, they have said, okay, the Member States now have to implement a stepwise approach by which they start doing pilots to see in which country, which way of doing prostate cancer screening is cost effective, is feasible, is accepted by men, etc.
Thank you.
And
Any other comments? Yeah,
if I could,
please.
if I could just jump in too, I'm going to come in kind of at an angle to the Hendrik van Poppel's response. You know, I'm not coming from a kind of a medical point of view, but from a health systems and kind of gender point of view. I think you mentioned something about men being different, right? And this idea that men don't go to clinics and they don't seek care. I think generally in most settings, there's an important element of truth to that we shouldn't let go. But I also think that the design of health services are also a really critical factor here, and whether or not they reach out to, anticipate, engage, or welcoming to proactively kind of engage with men, the way they do with, other groups. And so in addition to kind of clinically, epidemiologically, what may be a better screening strategy, I think there are also ways in which those screening strategies can better understand, anticipate, engage, and kind of welcome men as well, because that's at least half the problem, along with kind of masculinity and kind of other kind of cultural.
The openness of men to screening programs still is questionable for Europe. We know that in Scandinavia, where there's 21 different regions, they do screening programs now, systematic screening programs organized in 4 or 5 of them already. And the turnout of invited men in what I would say a country with a high health literacy, with a high prostate cancer incidence, is not more than 40 to 42%. So this means that more than half of men do in the 50 to 70 years of age range simply do not go. And if we look at breast cancer screening in Belgium, there's a 90% of turnout of ladies that have that examination in the screening program. So if even in a high health literacy country with a good awareness about prostate cancer, it's only 40%, one could wonder what would happen in the south of Europe, where the mortality is much lower, where the incidence is much lower, and the concern about health even less than in the north.
Chris, I wonder if you could respond to the question about the absence of sex disaggregated data, and why is that so, and how does one address that?
Well, let me just add, so I was asked to also add to that. So Well, let me actually put a couple questions together. So there was a question, actually, let me go back to one question. Somebody's been waiting a little bit longer. So there's a question about, despite the breadth of your report and finding, was there any difference in low and middle income countries versus what you saw in essentially higher income countries in terms of the attention to cancer policy in those regions?
I can't say that we've gone into that level of detail because the focus was on global policy. We did seek out regional policies as well, and we found some European, some Americas, and so on. And we had a couple of national, so one of the reports was a Malawi report, for instance. And in there's reference to men. And clearly that, it's in reference to their sort of efforts to establish a men's health policy. But again, very similarly, it's very cursory, very light touch reference to men, no engagement on inequities. And even though that would be stated as a principle, gender equity, when you actually look at the interventions, it doesn't translate. There's no linkage. So I would say there's very little, and it's almost guided by global level absence of male gender equity references.
So I'm going to connect two questions. So there's a question in the chat by Ian Pete about why don't we still see sex disaggregated data, despite the fact that is it a political ploy? I won't touch that part, but there's a question of why, given that this evidence, this is kind of one of those we sometimes say is hidden in plain sight. This is not new information that men have been dying at these rates, and that they've been dying at higher rates than women. So why are men still persistently absent from policy, even though the evidence of the need has consistently been there? And why are we still not seeing this sex disaggregated data?
Well, I think your first question is the $64,000 question. I don't know if everyone gets that reference, but that's a kind of a big question. My general answers to that when I get asked have to do with, a lot of it is the ways in which the focus on women, which is in a range of health kind of problems as well as social problems, is entirely understandable and justified and critical and everything else. But along with that has come a kind of like the kind of victim perpetrator, bind, a kind of a framework that binds us in how we think about it. And we see this, I'm in South Africa and working with people who look at men and violence, for example. And South Africa has a huge rate of gender-based violence. And usually what that means is violence against women. And there are globally epidemic levels of violence against women in South Africa, right? And it's always like hard to do the and, not the but, right? But men are also suffering huge levels of violence, and it's not recognized. It's primarily recognized as a kind of criminal problem of kind of crime and justice, and not a health problem, right? And men's fears and experiences of violence aren't kind of on the radar, and I think that's because men are seen as the perpetrators, right? Or men are seen as the ones who are to blame for not going to the clinic and not, getting tested or whatever else. So one kind of shorthand answer, I guess, would be the power of that framing that we have, people who are responsible and people who are victims. And this is how we kind of organize our kind of thinking and our intervention. In terms of sex disaggregated data, I think it's partly driven by that, kind of assumption as well. I don't know the answer to this, but I wonder if it's surprising because there is again an important long-standing focus on women's greater burden in a range of areas, which requires evidence of that, right? Which would require sex disaggregated data. So that data must be out there. But I think a lot of that data comes from research, from certain, kind of special surveys, from not from routine health data. Routine health data may or may not collect sex disaggregated data, but the pattern has generally not been to report that. If you look at most WHO kind of routine annual reports, they don't include that or haven't until recently, right? There's this kind of some slow shifting in that pattern, but there's just this, again, a blind spot in the kind of routine reporting of data that it just doesn't appear unless it's a kind of a separate issue. So
we've got about 7 or 8 minutes left. So Natalie, I know you're trying to get in there. I also want to make sure I get to a couple of the other questions, issues that were raised in here, and then give you each at least a minute or so to close up. So go ahead, Natalie, and then let me ask these quick questions, hopefully quick questions, and then
I think just to add to that, looking at the reports, my sense is that where a report sets out to actually focus in on disparities, be it racial, minority, migrant, vulnerable groups, or gender, then the data, appropriate data, gets provided. So the data is out there, but if you don't have that as your focus, you're not going to use the data. So I would also say that perhaps one needs to look at, when you're looking to address specific gender disparities, to actually commission the work and find the data to support that focus in your policy review.
So let me ask a couple of quick questions well, this should be relatively quick. So Dr. Shattuck from Hopkins, thank you so Hopkins, was asking if the report differentiates or synthesizes behavioral factors in medical interventions in terms of the types of policies that they're promoting, and in terms of types of initiatives that are being discussed.
Chris?
and whether there's a kind of a gendered element to that.
Well, just I guess, yeah, was it even covered? Yeah, were those things coming up in the reports that you reviewed?
Natalie maybe can answer more specifically, but my sense is that these policies they're quite high level, and when they do get into interventions, they're mostly focused on medical interventions. Okay. Is that?
Yes, I would say we looked at the full spectrum from prevention, promotion to care, treatment and care. But most global policies on cancer would be prevention, starting with screening and awareness, and ending with treatment and access to medicine and post cancer diagnosis care. However, we looked at health risk, NCD-related risks for cancer policies, and those are much more focused on prevention, such as the NCD Alliance and WHO NCD reports.
So last quick question. There's a question in here from Robin Hadley about premature mortality among, they found high rates of premature mortality, I guess, for particularly all-cause mortality and heart disease for lone fathers and childless men. This was about 20 years ago that they did the study. Was there any specific data from this group on cancer? Or I'm sorry, is there any data connecting this to cancer mortality that you're aware of? I think this is really beyond the scope of the report, but I thought I would just.
We didn't focus on that, but we have also done a report on mental health, men and mental health review. And I think there we're starting to see that, the effects of the sort of biomedical effects of mental health, including issues of loneliness, men, single men living alone, etc. So no, we don't have specific information on that, but I think broader scope of other reports might highlight that.
So stay tuned. So in the last couple of minutes, we're going to literally ask you to do just a minute each to close this out. I think actually Richard, I don't see Richard on here anymore. I want to sort of have you just offer any closing thoughts, but as part of that, if you can think about, are there any particular cancer policy issues that you think global action should focus on, or any ways that we should sort of incorporate this as an organizational focus?
I think to start with, I would just say that in the report, we also speak about some of the advocacy organizations that you might want to engage with more. And the Union for International Cancer Control is one of those, because they seem to have a very clear advocacy agenda that speaks closely to WHO policy formation. And then, of course, WHO in particular, and especially the World Health Assembly, that would be a high-level area where if you can get it on that agenda, that's a good point to start. And then research agencies as well, like the World Cancer Research Fund International, the American Association for Cancer Research, and international, like NIH, MRC UK, etc. I think attention there would also be opportunities for advocacy. So I'll stop there.
If I may,
Yeah, and I think
there is one thing that needs more attention in my view. Is the risk professional, the risk people at risk to the industry, to their profession, with exposure to toxic agents. That is more frequent, obviously, in men than in women, where we will probably start working soon within the EAU about bladder cancer. There's obvious tobacco, but that's the same risk factors as for lung cancer. There is kidney cancer that has common instigators, I would say, as lung cancer. So if we start lung cancer screening with CT scan, it would suffice to just have a CT scan extending to the upper abdomen to also include the kidneys. And I think that in these professional cancers, in these really people at high risk in certain areas and in certain industries, that might be a point of attention for men as well.
Absolutely.
Chris, you want to close this out?
Yeah, I guess 2 points. One is that despite the fact that a lot of my work is in evidence synthesis and kind of trying to understand and synthesize and present evidence across a range of issues, I think it's really important to remember that evidence doesn't change policy by itself, and that the advocacy kind of component is really critical, and kind of thinking through that as a political problem rather than a scientific problem. And then the second thought is that, I got into work on men through HIV and had a whole, long number of years working in that. And then I started working in men in TB and discovered a whole parallel literature, parallel to set institutions and advocates and whatever else. And now I'm looking in cancer and, discovering the same kind of thing. And so I think those cross, disease coalitions are really critical as well, so that we're not all kind of reinventing the wheel.
All right. Well, thank you all. On behalf of Global Action on Men's Health, thank you for your active participation, for your attention. Thank you to all of our speakers, Richard in his absence, Hendrik, Natalie, and of course, Christopher. Thank you on behalf of people. Thank you to Peter for organizing all this. Please continue to pay attention and be aware of our next one and support our next one, which will probably be Christopher and Natalie's report on mental health, which will come later this year. So happy Men's Health Week. Take care all.
Thank you very much.
Thank you.
Bye-bye.
Bye.